that in the lateral view, these three lines are seen. In the AP view, the spinous processes are in one line. If any spinous process is deviated, it may indicate a local pathology. And you must see whether the lateral edges of the vertebra, they are aligned or not. So this alignment is checked both in the lateral view and the spinal and the AP view as I have described. Then height of each vertebral body from C3 to C6 is almost equal. You look that the height is almost equal, it should be equal. Margins are smooth, margins should be smooth and regular. If you see this X-ray of the lateral spine, if you notice the margins of this vertebra are not regular. There seems to be sclerosis and they seem to be irregular. And there is not a proper alignment is not there. The anterior bodies are not in one line. There seems to be a forward shift. It may and the margins are not regular. So make note of these findings. Talking about this spaces, this space should be approximately equal in the spinal, which I've already shown you. I don't think I need to elaborate any further. Talking about the soft tissue shadow, I'll spend some time here. You must understand what are the normal soft tissue shadows which are seen in the cervical spine. At C1, you are able to see nasopharyngeal space shadow, which should be less than 10 millimeter. If this shadow is more than 10 millimeters, it increases either a traumatic lesion at the C1, C2, or maybe a tuberculosis. At C2 to C4, if you see, you see that in the lateral view, the paraspinal shadow is quite narrow and near till C4. After that, the normal shadow is increased. There is a thumb rule of 4 and 14. Till 4 millimeter, till C4 is normal. Below C4 till 14 millimeters. Rule of 4 and 14. At C1, 10 millimeter, C2 to C4, 4 millimeter, below 4 millimeter up to 14 millimeter is normal. These are the normal dimensions of the soft tissue shadow seen in the cervical spine. If you find any changes, then you must suspect a pathology. In AP view, once talking about the soft tissue shadows, you must make any note of any surgical emphysema, which may be seen in a case of C7 vertebra. Now talking of some special fracture. Now I'm talking of traumatic X-rays in cervical spine. This is a Jefferson fracture or the compression fracture of C1. Basically, there is a widening of the lateral muscles of C1, which are more clearly seen in the open mouth view. They are supposed to be in there is a disruption of the lateral muscles in C1. It is called a Jefferson fracture. There is a splitting of the lateral muscles. It is caused by mostly a fall of heavy object on the head. But this is a typical finding of a Jefferson fracture. This is a hangman's fracture, which is basically a fracture of the C2. There is a increase in nasopharynx, the shadow, soft tissue shadow, which I told you should not be more than 10 millimeter, which is more than 10 millimeter in this X-ray. And there is anterior dislocation of C2 vertebra, and there is a bilateral C2 pedicle fracture. Here, you can see it here. There is a line diagram of the same film. You can see there is a dislocation. Here, there is a fracture and increase in the shadow. This is a typical hangman's fracture. A clave shoulder fracture is a injury of the severe hyperflexion of the cervical spine. There is a avulsion fracture of spinal process from anywhere from C6 to T1. Like in this case, you can make out, the picture is not very clear, but this is a line diagram of the same thing. Now the fracture of the odontal process, which you can see in the open mouth view, there are basically three types. Fracture of the tip, type 1, which is a tip. Type 2 is the base, which is the most common and is unstable. And the type 3 is through the body. Type 1 and type 3 are stable. Type 2 is unstable. Type 2 fracture occurs at the base of the odontoid process. Now, the different injury patterns which may be seen in the cervical spine. The first injury pattern which is seen is the hyperflexion compression injury. The center of rotation of the forces, it is just behind the anterior column. There is a progressive compression failure of anterior column. There is a teardrop fragment from the anterior vertebral body. You can see it here. And the posterior body subluxates into the cervical spine. You can see it here. The same thing here. This is a typical hyperflexion compression injury of the cervical spine. The second one is a vertical compression fracture. You may say that it resembles a burst fracture. The compressive forces are exerted vertically to the spinal column. There is axial loading injury and compression failure of the anterior column. Posterior column mostly remains intact, but if it fails with increasing compression injury, it fails in compression. Then there are hyperflexion distraction injury. The very first example you saw, hyperflexion compression injury. This hyperflexion distraction injury. There is hyperflexion flexion vector at the anterior column, and the posterior column opens up. There is distraction injury. Hyperflexion distraction injury. Then there is a hyperflexion, hyperextension compression injury. The center rotation is behind the anterior column, resulting in the axial loading forces applied to the posterior column basically. The main forces at the posterior column, resulting in compression failure of the posterior column. With increasing magnitude of the force, the anterior column distracts. Then there are hyperextension distraction injury, in which there is a extension vector with center rotation posterior to the vertebral column. The axis of rotation is somewhere behind the spinal column, resulting in distraction and tensile failure of the anterior column, showing a small fracture here. Once the force increases, there is a hyperextension dislocation of the spine. So these are the different patterns which are seen in the trauma of the cervical spine. Coming to cervical spine, now I told you already, I am not going to repeat whatever I've shown you examples of infective focus in the dorsal spine. Infective focus in the cervical spine will be almost similar. With the in a cold abscess will be increase in loss of soft tissue space. Now let me show you an example of a cervical spondylosis. Again, there is a loss of vertebral height. Anterior osteophytes are seen, which are seen at the margins of the vertebral body, and there is narrowing of the foramina, which may be seen in this case. Now, rheumatoid arthritis, I've picked up this Excel to show you that be aware of this thing. Then once the rheumatoid arthritis affects the cervical spine, then chances of atlantoaxial subluxation are quite high. Specifically, look for any evidence of atlantoaxial subluxation or dislocation in a case of rheumatoid arthritis if it is affecting the cervical spine. Actually, a word of caution, while operating any patient of rheumatoid arthritis at some other place, like a hip joint disease, an X-ray of the cervical spine must be done to ensure that the patient doesn't wakes up with quadriplegia. So the findings in the rheumatoid arthritis are atlantoaxial subluxation, atlanteal impaction of the cephalate migration of C2 vertebra, erosion and fusion of the vertebral and facet joints, in general osteoporotic fracture, and erosions of spinal process. These are the findings which are seen in a case of rheumatoid cervical spine. Ankylosing spondylitis, if it affects cervical spine, which is late and rare compared to the dorsal spine involvement, there's extensive fusion of the cervical spine in general, which is seen in the facet joints are also fused, and you can see that in the fused cervical spine looks like in a case of ankylosing spondylitis. In the last I'll talk about a common tumor in a case of cervical spine. Osteoblastoma is a benign bone tumor which is actually resembled osteoid osteoma as far as histopathology is concerned. And osteoid osteoma is less than 1.5 millimeter, when an osteoblastoma is more than 1.5 millimeter. This is an example of a osteoblastoma in a spinous process of C4 vertebra. This osteoblastoma, I have picked up this example because osteoblastomas are 50% of these cases occur in spine. That is why I have 50% of all cases of osteoblastoma occur in spine. Like in this case, they are differentiated from osteoma only on the size. Otherwise, the pathology is similar. They are typically osteolytic. Sometimes they have some calcification which can be picked up only on a CT scan. And this is an example of a metastasis, which is the commonest tumor of the spine in general, and the same is true for the cervical spine also. And I think I'll finish here. Thank you so much. I think I have tried to tell you about something about how to interpret X-ray of the spine in an exam. I think I'll finish here.
Thank you, Dr. Sudhir Kapoor, for an excellent presentation. Professor, sir, can you unshare your screen?
Okay.
Yes. Actually, Dr. Rajshekharan has to go. So there are many questions for him. So Dr. Rajshekharan, can I ask the question to you from the audience?
Yeah, so I got those questions from, can I share my screen? Because
Yes, sir, you can share.
Is it seen now?
Yes, sir.
Yes, sir, visible, sir.
Is my screen seen?
Yes, sir.
Yeah,
yes,
visible,
sir.
Sir. Please go ahead, sir.
Yeah, so first question was why sometimes in spinal tuberculosis there is a discrepancy between the bone neurology and bone and neurology.
Because now the screen is not visible, sir.
Oh, screen is not seen? Okay. Now, let me do that. Sorry. Okay, I was just going to, I put some slides to explain this. I'm not sure whether. Is my screen? No? Okay, now it's there. Yeah. Is it seen now?
Yes, sir.
Yes, sir, visible, sir.
Okay. So the first question was why in spinal tuberculosis we have a difference between sometimes bone level and then neurology level. Now the causes for this is two. Now when you look at the bone level and you try to assess what is the bone level, you may look only at the radiology or a CT scan. And here you may think that this is the most important level. But you can see here, there are two reasons why this level may be different. You may be missing a skip lesion higher above. Can you see here? There is a skip lesion much higher above here over here. So there may be an occult lesion, which is a skip lesion higher level, or even within the identified level, when you take an MRI, you will find that the epidural abscess and the intraspinal compression and involvement of the nerve of the spinal cord is at a much higher level than the bony level. So the bone level which you identify in the X-ray or the CT scan may be at one level, but the intradural component, intraspinal component of the epidural abscess and the granulation tissue may be extending to 2 or 3 levels above that. And this may be one of the reasons why you have a bone neurology level discrepancy. And whenever you have a discrepancy, please take an MRI to make sure that there is no skip lesion at a higher level, as you can see in this patient very clearly. So I just put this MRI to illustrate these 2 points. Secondly, you must also realize that there is a discrepancy between the cord level and the vertebra level. So at C1 to 4, the vertebra and the cord almost are at the same level segment. But when you are coming to the bone level of C5 to T1, the cord level is always one more, which I mean is if there is a C5 bone level, the C6 cord is involved. As you come down, this increases between T2 to T5. You have to add 2 to the cord segment, which means that if T5 bone level is involved, then it is T7 cord which is involved. And as you come at T9, you have to add 3, which means T9 cord, T9 bone level, it will be T12 of cord level. And after that, there is a rapid difference. When you see between the two segments, bone levels of T10 to T12, you have the entire lumbar spine segments involved. And at L1, you actually get the conus. This is the conus lesion. All of the S1 to S4 is involved. And between L2 and S2, that is the corda. So this table must be imprinted in your mind. So there is a natural difference between the bone level and the cord level. And also in TB spine especially, the intraspinal compression may extend a few segments above because of the large amount of granulation tissue and the epidural abscess. So this is the reason why there is a bone level and neurology discrepancy. The second question was that what is the difference between the dermatome of the spinal level and the peripheral nerve level? Now, I put up these two figures quickly so that there is a very clear difference. So here, when you look at the upper limb, a dermatome is the segment of the skin which relates to the spinal level, that is the spinal nerve root. So if you look at C6, then you can see, especially in your, let's take the hand, and here you can easily differentiate. In the hand, the thumb and the index finger corresponds to C6. The middle finger corresponds to C7 nerve root, and the medial two fingers correspond to C8. But this is the root level. But if you look at the peripheral nerve, you will know that the ulnar nerve is a mixture of C8 and T1, and so it corresponds to the medial 1.5 fingers, and the median nerve corresponds to the lateral 3.5 fingers. So the sensory distribution, what you talk about on the skin of peripheral nerve, is completely different from what is at the root level. When you're doing a spinal examination, you're talking about dermatome. You're not talking about the peripheral nerve distribution. So you must keep this very clearly in your mind. Another question was, can you show us examples of knuckle deformity, angular deformity, and globular deformity? So I have put 3 figures to show what is the difference. Now, this is exactly the knuckle. Now, if you can see over here, a knuckle deformity is formed when you have one single vertebra involved. So when the single vertebra is involved, that specific spinous process becomes very prominent, as you can see as a knuckle over here. So this is called a knuckle deformity. It happens in a single body involvement in spinal tuberculosis, or also you can see very prominently, although we call it as a step-off sign, it is also seen very prominently in spondylolisthesis. An angular kyphosis occurs when 2 or 3 vertebrae is involved, and there is a sharp kyphosis over here. Whereas the classic example for a globular rounded kyphosis is Schuermann's kyphosis, where the kyphosis occurs over a large segment with multiple wedging. It can happen in osteoporotic collapse of multiple vertebrae, or Schuermann's kyphosis is the classic example. So here is a knuckle deformity on the left side. There is an angular kyphosis on the middle, and you get a globular kyphosis of Schuermann's kyphosis on your right side. So this is the 3 classic example. The next example, the next question was, I'm just showing again in the MRI how it looks. Single vertebral collapse gives rise to a knuckle deformity. Gibbous is after 2 or 3 vertebrae, and rounded kyphosis or a buckling collapse occurs when multiple reversal. The next question was, what is meant by vertebral decompensation? Now, when you inspect a back, you call a spine decompensated when there is a translation of the trunk over the pelvis. Now, in between, there may be a deformity, as you can see over here. Now, both these cases have got a deformity. You can see that there is a scoliosis in both these patients. But when you draw a plumb line from C7 and you drop the plumb line down, when it goes centrally over S1, then this patient is compensated. C7 is exactly over S1, but in between there is a deformity. So you will call this, when you describe in your clinical examination, you will say that there is a thoracic deformity to the right side, but the plumb line is maintained and the spine is compensated. In contrast, over here, you will find that this is a scoliosis and this is a list where there is a complete decompensation. You can see that there is a deformity of the thoracic spine, but the entire thorax is shifted laterally. So when you draw a plumb line from C7 down, it is not going through S1. So here is a case of example of a deformity which is decompensated. And similarly in the list, this is coronally decompensated, but the same thing can happen in sagittally also. So you can see that in this patient with an adult deformity, there is both a coronal decompensation and a sagittal decompensation, because if you draw a plumb line from C7, it is not going to go through S1. It is still. So here is a patient with a deformity, and on the right side, you have got also an adult degenerative scoliosis with lumbar canal stenosis, where the patient is stooped forward, and you will call it as deformity. So these are all the questions that have been asked for me, and I quickly put up some slides to make it look more explanative.
Thank you, Doctor.
So another question which asks if someone gets a female patient in the exam and you're not able to do a detailed neurological examination, what to do? A detailed neurological examination is easily possible in a female patient, except there may be a little bit of a problem in doing the anal sensations and PR. But as much as it is a difficulty for you, the examiners will know the difficulty. So you have to say that I have not done this. So it is just that the examiner wants to know that you know that it has to be done. So explain your difficulty to the patient. The last one is from Dr. Lalit Nagare. He has asked, what is an upper motor neuron lesion and a lower motor neuron lesion? Now, upper motor neuron lesion is a lesion due to a compression on the cord. And the lower motor neuron lesion is a compression on the cauda equina. The cauda equina represents the lower motor neuron lesion. So I just simplified it very generally. An upper motor neuron lesion is always involved with spasticity. There is an increase in tone. And so there will always be a spasticity, increased in tone. Because the tone is increased, it is not associated with a loss of muscle bulk. These muscles are constantly in hypertonicity, hyperactive, and the loss of muscle bulk is not very prominent in these patients. And there is an increase in deep tendon reflexes. The opposite is true for lower motor neuron. There is a loss of tone, there is a weakness. Because there is a loss of tone and weakness, the muscle bulk loss is very prominent, and you have hyporeflexia in these patients. So these were the 4 questions which are asked, and I just put up these slides to quickly explain this over.
Thank you, Professor Rajshekharan.
So
Dr. Sudhir Kapoor, there is a question for you. In Indian scenario, low backache due to diseases like tuberculosis, metastasis, or traumatic pathologies, is there any significance of doing X-rays in lateral flexion or lateral view in flexion and extension? Should we ask for them routinely? Sir, we can't hear you. Dr. Sudhir, we can't hear you. Unmute yourself.
Yes, I have unmuted myself. These are not required routinely, by your clinical examination and history, you will get a fair idea whether there is any possibility of instability or not. These X-rays are basically for instability. In those cases where the history and examination you suspect instability, then these become a must. As far as the second, that is one thing. Second thing, once you are assessing a scoliosis patient, in those cases, a lateral view side bending, they are also required in both the sides. In scoliosis patient, anteroposterior view with side bending to the right side and the left side, lateral view when you are suspecting instability, lateral view in flexion and extension when you are suspecting instability.
Thank you, Dr. Thank you, Dr. Sudhir Kapoor. Dr. Naresh Babu, you be ready with your presentation, and I'll take comment of Professor Raj Gopalan. Dr. Raj Gopalan.
Sorry, I could join only in the middle of Rashtriya's talk. I was held up in the hospital. Going on nicely. Please carry on. We are behind schedule.
Okay. Dr. Naresh Babu, please.
Sir, good evening. Sir, I am audible?
Yes, yes.
Yes, sir. Yes, sir.
Audible, sir. Please go ahead.
Audible, sir.
So I'm just moving ahead after radiological examination. The gold standard investigation of any spine patient is the MRI of the spine. Okay. The objectives of this presentation is to identify the orientation of the image which we usually use in spine, and MRI image types, different types of MRI image sequences, and the knowledge of some anatomical structures which are normal and some variations, and to identify a few of the pathologies. So even though it's basically a talk on spine and entirety, I will try to focus mostly on the lumbar spine because that is the commonest one and easy to understand, and the same findings can be extrapolated to other regions. 2 or 3 slides about the MRI physics. So how does the MRI really works? Because every tissue has got a lot of atoms which are spinning, which will be spinning around their own magnetic field. And once we apply high external field of magnet, they will align into a straight line. So these are the atoms of the tissue which are spinning in a random direction like tops around the individual magnetic fields. Once we apply a magnetic field by an MRI, these atoms will line up either to South Pole or North Pole. But about half of the atoms will turn either way, but there are few atoms which are unmatched atoms. And these are the ones which are very important. For these unmatched atoms, then we apply a radio frequency pulse in the MRI machine. Once this radio frequency pulse is applied, these unmatched atoms spin in the other direction. So once we stop the radio frequency pulse, they will come back to normal position. So this difference of movement will emit a lot of energy, and this energy is captured, and that will be computed by the digitalized by the software, and we'll get a MRI image. So the atoms will be spinning around. Once we apply a magnetic field, then we will align them in a single direction, but few will be not in the south or north pole. Then we apply radio frequency energy, and then the atoms will spin into opposite direction. Then once we stop that radio frequency pulse, they will come back to normalcy. This difference of movement will produce energy. That energy is converted into image. So that is a very simplification of the high-end technology behind the MRI. So few things about the planes. Once the radiological examination, as of now we have listened from Professor Sudhir Kapoor, is a 2-dimensional image. But the MRI has got a potential to get it in a 3-dimensional image. So this is the sagittal plane from front to back, and we have this is the coronal plane from the side, and the axial plane which comes from the different sections of the body. There are 3 planes which are very important. You may be asked in the examinations to identify the orientation and images itself. So each image will have different orientation, and they will be different sequences which are taken with different slice thickness at different intervals of the distance. So sagittal images, they are the lengthwise images. They are similar to our radiological lateral views. So you have fair idea about these images and easy to understand and interpret in correlation with the X-rays.
Hello.
The advantage of the sagittal images is you can get an entire spine in a single image and they resemble lateral lumbar X-ray. So we need to determine from the direction of it, from right to left or left to right, which is the orientation which is described in the MRI. And you should also consider that this is not limited to lumbar spine. Unlike if you are examining a joint like a hip joint, then you can only take for the hip joint. But if you are examining a spine, you should not be restricted to lumbar spine. That's what we are trying to impress upon. So spine is a single joint. It's not like lumbar spine is an incomplete joint. So entire spine is a single joint.
Hello.
Anything which you talk about the spine it should be full spine. Why it is important? Because there are a lot of structures, a lot of pathologies or diseases which can be easily picked up by these full spine sequence images. You can see one fracture here, and there is a contiguous fracture, non-contiguous fracture happening somewhere adjacent to it, and there is a fracture here, and there is a cervical stenosis in the upper part. All these sequences can be easily identified in the MRI. This is the greatest advantage of MRI to get a whole spine imaging at once. The axial images are the cross-sectional anatomy. The structures, so you need to understand the structures appear reversed in axial images. I'll come to that in the next slide. From the left side of the body, it appears under the right. We actually go into the basics of how they take axial images. All the printed images or images what we are seeing on a film are actually we are looking at the patient from the foot end. So what happens is the patient's right becomes image's left. So if you see this image actually, this is the right side of the image. The right is actually left side of the patient. The left is actually right side of the patient. So our mind should get oriented to that because as if that we are looking the patient from the foot end. The coronal images are rarely done, but they also carry a lot of information. But whenever you are doubt, you need to ask for a full sequence of coronal images. They are very useful if you want to analyze the sacroiliac joints. And sometimes when the patient has got conjoint roots in the lumbar spine, they can easily pick up. And they are also useful if the patient has got a lot of cold abscess in the upper thoracic spine or the psoas muscle involvement, psoas shadows, they can easily pick up in the coronal images. So next thing is identifying the image sequences. Because few of the centers have a policy to label the disc which they are printing, like L1, L2 disc, L2, L2 disc. They are the policy to label. And few institutes, they don't label it, they will just print the images and they will give you one pilot image like this, a scout film or pilot image like this. Then you need to identify these numbers which are on the side and the corresponding is the level of the cut what we are going to take. So in the sagittal plane, you get the axial references. In the coronal plane, you get the sagittal references. The sagittals can be mid-sagittal ones or parasagittal ones, or you can go to far lateral ones as well. So this is very important, especially if the patient has got a transitional segment. The radiologist will label it as L5 and we may feel it as a S1 because it's sacralized. The numbering becomes very big problem. So you need to actually note the number which is printed on the side of the image and correlate it with the printed image. Coming to the sequences which are commonly used, the T2 weighted images is the most common one which is easy to understand and most of the times we identify it. Anatomy is well seen on T2 images and T1 weighted images are the mostly important for the pathology identification and fat suppression or stereo images in additional cases. So how do we differentiate between these two images, T1 and T2? This is all difference between the black and white. The only difference between T1 and T2 is the black and white. T2, water is white in T2. So one thing which you need to remember, W and W, 2 times W, so T2. Water is white on T2 and water is black on T1. And difficult to differentiate CSF from the nose, that's we need to identify in the T1 because both are waters and disc of the contents of the central canal is difficult. So this is a simple table by which you can differentiate. Bone appears neutral imaging, bone T1 and T2. Air is dark on both the sequences. The fat is bright on T1 and it is little light on T2. So it's very difficult. Most of the times they appear little more or less the same. So fat on the both T1 and T2 will be almost with little difference. The water is dark on T1. This is a very important one. So water meaning the CSF or the abscess is dark on the T1 and it's bright on T2. So just to compare, the bone appears neutral in both T1 and T2, and the CSF is dark on T1, and CSF is bright on T2, and the air is dark on both the things, and the fat almost appears almost same intensity on both the images. So how do you differentiate T1 and T2 image? You have to see at the CSF column. If you see CSF column dark, that is a T1 image. The CSF column is bright, that is a T2 image. Then you can compare with the discs and other things. And the fat is bright on here. You need to identify the CSF and the disc and the fat. These are the common things which will pinch you the sequence identification. The few interesting things, this is a T1 weighted image and this is a T2 weighted image. In the T1 weighted image, you are seeing a big hyperintense lesion inside the spinal cord. This is also a hyperintense lesion inside the spinal canal in the T2 as well. And this intensity is almost looking similar to that of CSF. But you don't know whether it is a fluid or a fat. So how do you do that? How do you differentiate those things? Then you need to get a fat suppression image. This is the fat suppression sequence or stir image, inversion recovery sequence, which we call it as. If you apply that one, then you have to compare that one with the T2 weighted image, and you see the fat is suppressed here, comparing the other one. So it is a lipoma of the spinal cord. So the sequence or systematic interpretation, the first thing is to identify so these are the ones which we need to identify when you are actually referring. The timing of the MRI done, because many times a lot of patients come with a different sequence of different MRIs, maybe 6 months prior MRI and 1 year prior MRI and the most recent one MRI. The pathology, which is dynamic pathologies, can keep on changing. The timing and the patient identification, then you first look at the T2 sagittals and then T1 sagittals and T2 axials and T1 axials. And then once you have come to a fair conclusion, then read the radiologist report. Most of the times these radiologist reports are like a big essay papers describing most of the anatomical features. But which is clinically relevant is a big question. That's where the clinical significance comes in. Determine which of the radiological findings are clinically significant. So we keep seeing the MRI reports, degeneration from L1, L2 to L5, S1, but actually the patient may be having a significant degeneration only at one level, which is clinically relevant. That's where our clinical equipment comes into force. So coming into the sequential analysis of the identification of normal anatomy and pathologies in the sagittal view. So you need to travel the body from posterior to anterior. So these sections are actually taking the sections from posterior to anterior and from the scrolling from the left to right. How do you identify which side of the spine we are looking at? By looking at the aorta. If you can see the aorta is on the left side, on the inferior vena cava is on the right side. And mid-sagittal section is the most important, easily understood structure, especially for the spinal cord and the discs. Discs are widely seen on the mid-sagittal sections. And you can see vertebral bodies, mid-sagittal sections in the mid-sagittal lamina, spinous process can be seen in the mid-sagittal one. The cardiac vena can be seen, but you can't see the facets, pedicles, transverse process, neural foramen. You can only see the center of the spine. So this is how it looks in the mid-sagittal spine. Once you see, the examiner may ask you which is the level of this MRI, whether it is mid-sagittal or parasagittal or pedicle level. So how do you identify that? If you see a good disc here and a rectangular vertebral body and entire spinal cord is seen and some amount of spinous process, then this is a mid-sagittal image. You can't see pedicles here, you can't see articular process here, you can't see neural foramen here. So once you go little lateral paramedian, which intersects the vertebral bodies, discs and vertebral canals, lamina posteriorly, but does not intersect the facets again. So how does it look in the paramedian view? you can see a part of spinous process in the back. And the vertebral body looks a little bit of wedged shape. The distance of the anterior posterior appears little different. You may see vena cava on the right side and aorta on the left side in the mid-sagittal sections. But you still can't see the nerve root foramina, the keyholes, what we clearly see on the parasagittal sections, we still can't be seen. So that's how it looks in the paramedian one. The transpedicular section, this is the most important section where you can identify the foraminal area in the lateral part. So where you see the lateral vertebral body, pedicles, and intervertebral foramen, spinal nerves and facet joints. These are the ones which are clearly seen in the transpedicular view, which is a little paramedian view. But you can't see again spinous process because we already passed that one. Transverse process, nucleus pulposus, caudicum, those can't be seen. So this is how it looks in the pedicular section. This is very important to see. These are the ones which are, the yellow ones are the nerve roots. And you see a lot of fat covering the yellow the nerve root, and there is a lot of free space. This is the keyhole shape. This keyhole shape, if it is compromised, then we call them as a foraminal compression things. So this is the one, this is how it looks on the paramedian section. You can see the pedicle, you can see the nerve root, and you can also see a fat sleeve covering the nerve root and the articular surfaces above and below. So these nerve roots naturally, they change the shape. So the orientation of the nerve root is wider at alpha S1. They are little narrow and the oblique as you go up. So this is what which is important in looking at the spine. So how do you read the MRI in the sagittal view is very important. So you need to, it's the same as how do you read a lateral lumbosacral spine X-ray. So, mnemonic is being A, B, C, D. So alignment, bones, cord or canal, and the disc spaces. These are the ones which are very important. This MRI, which is depicts almost all the pathologies which we can see. There is a alpha S1 fusion there and 4-5 listhesis that is mildly moved out. And bones, you can see that there are two compression fractures in the vertebral two vertebrae, and the canal is stenotic here, and the disc spaces are degenerated, and a few of the discs are prolapsed. So a lot of anatomical features can be picked up quite nicely in the sagittal view. Other two important alignment things which we come across in day-to-day practice or in exams is spondylolisthesis. We need to identify where the listhetic segment is, and the gibbous deformity of the thoracic spine, and the internal gibbous, which is the main reason for the compression. Other places where this anatomy alignment can be altered is trauma and congenital things. But we are not supposed to comment on the natural curves of the spine on MRI, because MRI is taken in supine posture. The cervical kyphosis, cervical lordosis, lumbar lordosis, or lumbar kyphosis, those comments should not be made on a MRI which is taken in lying position. So alteration of natural curves, or even the listhesis, suspicion of listhesis, if it is visible on MRI, you can comment, but the dynamic nature of those listhesis cannot be identified on a supine MRI. Other structure, next one is the bone. Once you have cleared that one, then come to the bone. Bone is there is a focal diffuse marrow abnormality. What is seen in the bone is very important, whether there is a alteration in the signal intensities of the bone marrow. You may need stirring images or fat suppression images to identify recent fractures. Sometimes infections and tumors, trauma can be picked up, vertebral body trauma can be picked up very easily. The contrast will be a lot of times will be helpful in the vertebral body lesions as well. You can also see a few of the incidental findings in marrow in the vertebral body. The first image shows a circular hyperintense lesion in the vertebral body. The examiner may ask, what is this tumor? What could be the pathology? Is it the contributing factor for the pain? So these are the hemangiomas, which are incidental findings. Most of the times they are innocent, they don't contribute. And if you see the second image, there is multiple hyperintense signals in each vertebral body. So the pathology is, these are the normal sinovertebral vessels. If you take the cut exactly in the vertebral foramen area, you can see these white bands crossing across in the but they contain a little bit of fat. That's why it picked up as a white lesion. So this is a normal one. And again, the last image, you will see a little bit of change of signal intensity at the L5 lower vertebral body. So these are the mode exchanges associated with the disc prolapse. So they are the incidental findings. They don't contribute to the pathology, but they are nice to pick up on MRI and comment on those things. A few words about mode exchanges. I don't want to go into detail because these mode exchanges will confuse infection. There are 3 types of mode exchanges, 1, 2, and 3. Modic 1 is, it all depends on whether it is bright on T1 and T2 or both, or none. So that's why we differentiate. If the modic 2 is both are hyperintense in T1 and T2, it hyperintense in modic 2 and hypointense in modic 3. In modic 1, T1 is hypointense and T2 is hyperintense. So that's why we identify the significance of this. Maybe this will be covered in the second part of the series, I think. Then coming to the canal and the cord. Canal and cord has to be looked into. This is the major diagnostic pathology here. If you see the first image shows a lot of spinal canal stenosis, the anteroposterior reduction of the spinal canal. And the second image shows cord changes there is a myelomalacia in the cervical cord, which is the contributing factor for the pathology. And you can also pick up serines. A lot of tumors can be picked up on MRI as well. So a few things about tumors. The tumors can be extradural. The first image here is the extradural tumor. The black line is the dural sleeve, and the light green color one is the cord. The lesion is in front of the dural sac. It is called extradural. And if it is compressing, it is a compressing extradural lesion. The dura is intact and the cord gets slipped off. There is an intradural extramedullary lesion. You can also get intradural intramedullary lesions. So intradural intramedullary lesions, you don't see a separate indentation covering the dural sac. So the CSF will be flowing all across the tumor, but here the CSF will be displayed onto the one side. So this is very important to identify which is the level of the tumor. So one interesting point here is, or the point which you need to remember is, you can't get any intramedullary tumors below L1 because the spinal cord ends at L1. So never try to comment that this could be intramedullary, possibility of intramedullary, because the chorda icona starts at L1. So all intramedullary tumors are above L1. You can get intradural extramedullary tumors below L1. So there you can also see a few incidental findings of the canal, which is expansile lesions with the fluid-filled cavities like this. These are the tarlosis. So they may confuse, and examiner may ask leading questions about these links. These are the innocent cysts which are not contributing to most of the times they don't contribute to the pathology. They are identified as the incidental findings. Next, coming to the disc spaces. Disc spaces is the most common thing for which we need an MRI. I'll just explain them into the axial images. These axial images, interpretation is very important. So this gives a lot of information in addition to what we get in the sagittal sections. So we need to identify that the conus medullaris ends at L1, L2. If you see the axial sections without any cord inside the canal, then you are below the L1. And the dural sac terminates at S2. And lumbar spinal nerves are passing to the vertebral foramen. So a few anatomical structures which are very important to identify. These keep changing with the level from where we have taken this axial cut. So there is a vertebral body which is very clearly seen, and you can see the spinal canal here. And these are the exiting nerve roots. These are the traversing nerve roots inside the spinal canal. And the spinous process, facet joints, and there is a iliopsoas muscle in the front. And the abdominal fat is seen, and the iliac bone there, subcutaneous fat, and posterior rectus spinae muscles. So coming to the spine, so the nerve roots is very important to identify which are the nerve roots which are escaping. The L5 nerve root exit at L5S1 foramina, and these are the ones you need to differentiate between the traversing and existing nerve roots and the facet. I'll come to that in the next section. So a lot of structures surrounding these axial sections we can get in addition to the spinal anatomy. A lot of muscles surrounding the spine and visceral structures can also be seen. So there is the psoas muscle quadratus lumborum, common iliac veins and iliac arteries. The nerves, very important to understand about the exiting and the traversing nerve roots. What I'm trying to say, the exiting nerve root is the nerve which goes below the pedicle is the exiting nerve root. So here this is the L4 nerve root is the exiting nerve root here. This is the L5 nerve root. So when the disc prolapses, it usually compresses on the nerve which is below. That is the traversing nerve root. That means in a L4, L5 disc prolapse, L5 nerve roots get compressed. The same nerve root, the same disc can compress on the nerve root above, the L4 nerve root, if it prolapses laterally, far laterally, which we call as a far lateral disc. In the far lateral disc at L4-5, the nerve root which gets compressed is the L4. In a normal paracentral disc prolapse at L4-5, the nerve root which gets compressed is the L5. This is very important to understand because the distribution of the pain completely differs. In a L4-5 disc can cause L4 root radiculopathy. At the same time, L4-5 disc can also cause L5 radiculopathy if it is a parameter. So, how do you identify the anatomy of these things? The nerve root which escapes, that is the exiting nerve root which lies lateral to the disc, and the traversing nerve root lie just posterior to the disc there. And also the sections of the spine which you take at the different level will have different anatomy. If the cut is at a transpedicular level, you can only see vertebral body and the canal, and you can't see the disc there. I mean, you can't see the nerve roots and facets there. And if it is subpedicular, it goes through the dural slack, and you can also see a little bit of articular process. The facet joints are clearly seen when the cut is taken through the transdiscal one. Most of the times we will be examining these transdiscal pictures to come to the conclusion. In the transdiscal pictures, the structures which are anterior to the spine, most of the times we don't give much of importance to them, but the examiner may ask you about these things, and these are very important to identify the level of the spine as well. I'll quickly go through these things. The quadratus lumborum muscle, which lies lateral to the spinal transverse process and bilaterally. This quadratus lumborum, it starts from anterolateral aspects of 2/3 of transverse process from 12th rib to L5 spinous process, and you don't see any quadratus lumborum muscle at L5 transverse process. That is very important. If you don't see quadratus lumborum, you are actually looking at the L5 disc segment. The psoas major, which is the blue one here, the psoas major lies little ventral to the quadratus lumborum, but again the psoas major starts from the middle to one half of the transverse process, extends in front of the anterolateral border of the spine, and it narrows up in the lower lumbar levels. It increasingly becomes wider at the lower levels, and the fibers from the lower lumbar levels add this muscle. So you see a thick bulk of muscle over here. Next structure which you see little anterior is the crus of the diaphragm, both the sides, the two crura of the diaphragm on the anterolateral corners of the axial section. So here again, this crus of the diaphragm arises from the upper lumbar levels, and the left crus descends to L3, the right crus descends to L2. So this is very important. If you see only one crus, then you can identify the level of the lesion basing on that. And then aorta is seen in the front of the spine, and it bifurcates at the lower border of L2 into two common iliac arteries. And inferior vena cava is seen on the right side of the aorta, and inferior vena cava is formed at L5 via two common iliac veins, and it may be displaced by right crus. So if you see in the L1, L2 level, you'll see quadratus lumborum and psoas major. The right crus is seen and the left crus is also seen. Aorta is seen, inferior vena cava is seen. But if you come to L2-3, you will see quadratus lumborum and psoas major becomes little thicker, and inferior vena cava is still seen, aorta is still seen, but you can't see the right crus. If there is no right crus and you see the left crus, we are at roughly at L2-3 level. And again, if you are L3-4 level, you can't see both the crus. Both the crura has already left, and quadratus lumborum is seen. Psoas is very thick and bulky. You still can see inferior vena cava and the aorta. If you come one level down, this is a very important area where you see a thin quadratus lumborum, big psoas muscles on both the sides. And inferior vena cava seen as a single structure, and aorta has bifurcated into two common iliac arteries at L4. If you see two aorta, two arterial shadows, then you are at a L4-5 level or below L4-5 level. In L5-S1 level happens, you see four vascular circles. So two wings, which are the ones which are forming the inferior vena cava, and then the two common iliac arteries. And the psoas is seen, and you don't see quadratus lumborum here. So there are the few things which are important to understand from which level you are actually looking at. This is L3-4 level, which shows most of the things, and L4 level, I think I'll just skip this repetition. So to put it briefly, aorta at level of is seen at L1 to L4, and below L4 it replaced by common iliac arteries. Inferior vena cava at levels from L1 to L5, and below L5 it is replaced by two common iliac veins. And both cusps are seen at L1, but the left crus stops at L2 and right crus at L3. And psoas is seen at all levels, and it's small at L1 and becomes gradually thicker at L5. And quadratus lumborum starts at L1 but is absent below the transverse cross of L5. These are the few anatomical structures which are important to know. So in roughly below L5, four vessels are seen anterior to the spine, two common iliac arteries and two common iliac veins. If you see four vessels, we are at you are below the L5 levels. Between L4 and L5, you can see only three vessels. There is two common iliac arteries and one inferior vena cava. And there are a few muscles which are behind the spine, which are also important. The multifidus, which is becoming recently as a main stabilizer of the spine. So a lot of surgical procedures are now being introduced to preserve this multifidus muscle, as this is the main stabilizer of the spine. In addition to that, you see a lot of paraspinal muscles running around. So the few structures which are anterior to the spine, these are also may be interesting, because so curiosity examiner may ask you about what is this structure which is seen in front. So this is the uterus which is seen in front of the spine, and in front of the uterus what you see the fluid filled structures which is at hyperintense on T2 is the urinary bladder, and gas filled hypointense structure which is seen behind the uterus is the colon, rectum and colon. So you can see the anterior longitudinal ligaments, posterior longitudinal ligaments, and facets and ligament of flavum, few structures which are important onto the axial spine. So in the few anatomical structures in the coronal sections which are not familiar to us, but examiner may ask you to identify those structures. The spleen on the left side, and you can see liver on the right side here, and right kidney and left kidney. These are the ones. Sometimes you may see a small focal cystic lesions in the kidney which are seen as a fluid filled space which is glaring at the MRI, and you need to identify them as a cortical cysts in the kidney. And the iliopsoas muscle, these are the areas where usually you will find a cold abscess by displacing this muscle, causing a psoas shadow on the X-ray. And the vertebral bodies, and there are the deep abdominal adipose tissue. The white ones are the planes of the adipose tissue. In the posteriorly, spinous process and paraspinal muscles. And again, you can see the two kidneys there. Coming to the description of disc prolapse. So there are the few anatomical things which you need to identify. This is the final thing. After that, I'll quickly finish it up. Discs are different terminals are being used. So prolapses, broad-based disc, or herniation, extrusions. You may be asked to name what is it, is extrusion or protrusion or prolapse or bulging. So how do you type, the nomenclature used is the disc is actually separated into four equal quadrants by 25% of each, four quadrants, and that is the extension of the disc and the extension of the disc bulge. If the entire disc expands circumferentially, this is called disc bulge compared to the above level or below level. The spine, the disc expands circumferentially, that is called, is something like a tire which is worn out. It balloons out all around, that is a bulge. There could be asymmetrical bulge where it only bulges onto one side circumferentially. These are the examples of circumferential asymmetrical disc bulge. You can see there is no bulge on the right side, there is a little bit of bulge on the left side. And the disc herniation, this is the one where the margin, it comes out of the margins of the disc This is called herniated discs. And disc herniations, there are again broad-based disc herniation and focal disc herniations. We call it as a broad-based when this surface enters into crosses the one of the 25% of the disc cross section. We call it as a broad-based one. When it is limited to one quadrant, then we'll call it as a focal disc bulge. So these are the examples of broad-based ones on the focal disc bulges. And disc protrusions, when the disc comes out and protrudes, and then it is called a disc protrusion. This protrusion is called as a extrusion. When the base is broader, we call it as a protrusion. When the base is narrower, like when we find like a small waist which is formed between the major disc and the prolapse disc, then it is called extrusion. So these are the protrusions, and this is actually extrusions. And these extrusions in the sagittal view, they look like this. And it is still with the continuity of the the parent disc. It is still in continuity of the parent disc, it is called as a extrusion. This somehow it comes out and then elevates the PLL there. So sequestration is the one when there is a detachment of the fragment from the herniated disc. The fragment migrates. It can migrate into superiorly or inferiorly, which is picked up on the sagittal MRI. So other classification and terminology can use is actually contained disc and non-contained. These are all the normal terminologies which you see on a MRI report. Then you may be asked to relate them to the patient's symptoms and clinical features. When the posterior longitudinal ligament is intact and the disc is within a contained, this is called a contained disc. When the posterior longitudinal ligament tears apart and the disc comes out, it's called extra ligamentous non-contained disc herniation. So most of the sequestrations are extra ligamentous and non-contained. So these are the few of the examples of the focal disc herniations of the nerve root. So few points about the immediate post-operative spine. This is important. Once you get a case of a recurrent disc herniation as a small case or a spotter, you will be asked about the post-operative MRI spine. So post-operative MRI spine, if you take it immediately, you will see a lot of mass effect on the MRI. You can't differentiate what is what between the edema and the disc or the scar or the hematoma or the discitis. But the discitis definitely shows adjacent vertebral signal changes and the fluid formation within the disc, which is commonly seen in the discitis. One major important point you need to know about is how do you differentiate the recurrent disc or the scar post-operatively. The patient comes back with the recurrent symptoms. The only way we differentiate these two is by giving a contrast. You need to understand the disc is a vascular structure. Whenever you give a contrast, disc is not going to enhance. The scar is going to enhance. What enhances in a recurrent disc is a peripheral enhancement. The center will be dark, that doesn't enhance, and the periphery around the disc, which is herniated, will enhance. If you see in a T1 weighted axial sections, if there is enhancement peripheral to the lesion, then it is a recurrent disc prolapse. There is something hypointense structure within the peripheral enhancement, that is a disc fragment. If the T1 weighted thing, which is a scar tissue, it enhances enterity. So there is nothing inside there is no hypointense lesion. It enhances like a, so there is a direct blood supply to the scar. So whatever contrast you give, the scar also takes. So it becomes bright on post-contrast T1 weighted image. But the disc will be hypointense. It's only enhances in the periphery. So that is a one important point which you need to know about the scar. So to conclude, you need to analyze the spine in a global perspective. So larger and more obvious findings are to be noted first. Alignment of the spine by noting the spondylolisthesis, retrolisthesis, scoliosis. Scoliosis can be a little difficult to see the alignment on the spine, but partial views of the contoured view can be noted there. Vertebral body shape. Identify the end plate disruptions, small nodes, compression fractures, block vertebrae, and fusions in the vertebral body shape. And vertebral body content is also important. Whether there is a edema, tumor, fatty infiltration, or hemangiomas, you can pick it up. So once you have analyzed everything and you are trying to put them into a conclusive inference, you'll see a lot of normal findings can be seen, And then the few anatomical variants, coincidental findings, clinical significant findings, diagnostic findings, pathology, it narrows down to the pyramid. So when you are actually trying to opine on the MRI, actually you need to focus more on the pathology, and then the pyramid comes down. The normal findings has to be touched upon very little, and you have to focus more on the pathology. So thank you very much for your kind attention. Sir, Manish sir, you are muted, sir.
Thank you, Dr. Naresh Babu. Dr. Rajgopalan, we are falling short of time. Can we go to the next presentation and then we, take the question?
Yeah, I think so, because we have finished only 3 talks, sir.
Yeah.
I think we should go on to the next talk. We can probably have a question answer at the end.
Yeah. Dr. Samir Gupta, please.
Hello. Hello. Am I audible, Dr. Dhawan? Hello. Am I audible?
Sir, you are audible. Audible.
You are audible.
Okay. So I'll start my talk now. It is on anatomy and biomechanics of spine. In these that we just had, most of the anatomy has been covered, and some aspects of covered. I am not going into details of biomechanics. That's a very, very elaborate topic. But yes, I'll be giving you the basic ideas of how the very So when you look at the spine of 7 cervical vertebra, 12 thoracic vertebra, and as the child starts growing up after birth, say kyphoid curve, the lumbar lordotic curve. And what the main function of the spinal canal is to protect the spinal cord, provide mobility, and transfer loads. You have to understand that spine in the center of body transmits the weight of the body to our pelvis and from our pelvis to our lower limbs. So there's a lot of load which is being taken up by the spine. The spine, of course, consists of the vertebrae and then the ligaments which hold these vertebral bodies together. The most important ligaments are the supraspinal, interspinous ligament, the ligamentum flavum, and then on both sides, intertransverse ligament, posterior longitudinal ligament. There are the capsular ligaments of the facet joints, and then a very important portion of articulation between the vertebral bodies are the disc. These are how the various ligaments are oriented. Just to recapitulate, so that we start discussing further, we understand how these ligaments are oriented. Intervertebral disc is a very important part of our spinal cord, of our vertebral column. As we all know, there is a central nuclear pulposus, and on the periphery is the annulus fibrosus. This annulus fibrosus is attached to the end plates which are present on the tenacious structure, which consists of layers of collagen, which are oriented in different which are oriented in different planes. There have been various counts of these layers of annulus fibrosis, and at present the usual thought is there are about 90 layers of annulus fibrosis which bound the nucleus pulposus. The nucleus pulposus has hyaluronic acid and other organic molecules which attract water, which imbibes water. And as this nucleus pulposus is bound by the end plates on both ends and the annulus fibrosis in the periphery, there's a hydraulic cylinder which is relatively unyielding to the vertical pressures. And at some times, at some movements of the spine, this times the body weight of pressure. So you have to understand that annulus fibrosis holds the nucleus pulposus in place and disc so that the integrity of the spinal column is maintained. If something goes wrong with the annulus fibrosis, it may rupture, and then you have the collapse of the intervertebral disc. When the child is born, there is about 93% water content in the nucleus pulposus, and with aging, the physiological reduction of the water content at the age of about 80 years is to 70%, 75%. So from 93%, it goes down to 75%. But when degeneration is occurs, this can desiccate tremendously, becomes hard, and may completely lose its function of providing the cushioning between the two vertebral bodies. As the spine is subjected to a lot of pressures, jerks, and stresses, the disc, the intervertebral disc, acts as a shock absorber to prevent the vibrations, the shocks, the degenerative forces to reach up to the brain, and that's why it is an important structure. The nutrition of this intervertebral disc is through the end plates and not through the arteries from the side. There was a thinking initially that there are certain vessels which provide the nutrition to the periphery of annulus fibrosis, but now it's known it is only through the end plates. And if something goes wrong with the bone, then the disc also degenerates, as we see in case of tuberculosis of the spine. And this is the structure of the various vertebrae. This is a typical cervical vertebra. You can see that the facet joints here are oriented with superior-inferiorly. And this superior-inferiorly and partially coronally organized or arranged facet joints allow for a lot of flexion and extension of the cervical spine. Then if you look at this structure of the thoracic spine, you see these facets are arranged horizontally, and when one vertebra tends to move over another vertebra, it permits a rotational movements. It's a part of a bigger arch, and it permits rotational movements at the thoracic spine. So rotation. However, thoracic spine can permit a bit of flexion and flexion also. Age of ribs and sternum, which are present on the front and side, the excessive movements are prevented. These structure of the vertebrae and their facets are very important constraints to the spinal cord is enclosed in this canal, and bodies it can impinge upon these ligaments are very strong and have a very small, this very small tolerance to failure. That means that when they reach at their particular length, they don't stretch, they fail there. This is because excessive stretching of these ligaments can ultimately lead to compromise of the cord and it's a bit of stretching. And when rotational movements, but allows for lateral flexion moves to the spine. Now, when you look at the line of weight bearing or the axis, vertebral column, the axis of the vertebral column drops down meters, goes through the center and goes in front of sacral to vertebra. About an inch in front of second sacral vertebra. You have to remember that. It lies very low. Gravity prevents toppling of a low-lying center is also important so that the movement of the center of gravity while the person is walking is not much. See, when you look at the way the center of gravity traverses when a person walks, if we just center of gravity, we find it when the person is walking, it hardly deviates. Walking, there is a movement at the hips and knees. The body, the center of gravity does not move much. Why is this? If you look at the lifetime of a human being, an average human being walks so much that if he continues walking in one direction, he can encircle the earth 3 times in his normal average lifestyle. Now, if you have an automobile and you want that automobile to run, after some time, the parts give way. Because the amount of energy spent in locomotion is very low. And the amount of energy spent in locomotion is very low is because the center of gravity does not move much. It is like a big ball. If you're a 70 kg person, if you're walking, it is like a ball of 70 kg which is rolling on the ground. The center of gravity does not move much. And once the center of gravity does not move, the energy spent on movement is very less. So it is important that we maintain spine is very important. And if Dr. Rajgopal has told in his explanation in the later part of his talk, if the center of gravity moves away, not only the curve of the spine looks ugly, but also it produces a lot of degenerative processes because of the wear and tear, because of the excessive energy that is being utilized, and ultimately the various curves of the spine is oriented around the central axis of the spine. And whenever you are treating, you have to understand, when you look at the patient, you have to understand how these curves are maintained, and you have to analyze whether these curves are there in place where the axis is passing normally or it has deviated. Prehension, he's doing work with his upper limbs, he's moving, he's jumping, he's running. all this is stabilized by the spine and the maintains this fall down. This occurs by a way a system of three things: the passive subsystem of spinal column, which consists of bone and ligaments; the active subsystem, which consists of spinal muscles, which are very strong and which maintain the balance. We prevent excessive movements. We maintain the curve so that ultimately the center of gravity in the spinal axis is maintained. And then there is a feedback system of neural feedback, which tells the brain that what and which muscles to contact to bring them in balance. Now, as I was talking to you, this slide shows that in a normal adult who's standing, who's not doing anything, percentage of body weight above the LCL for pressure over the body. But even slight twisting, lateral bending, flexion, extension increases this. Suppose a person is trying to bend forward and lifting, say, 20 or 30 kg of weight, the amount of pressure generated in the disc can be phenomenal. And that's why fibrosis is such an important structure which maintains the integrity of nucleus fibrosis. The collapse or rupturing of this hydraulic tube, which is the disc, and helps in passing of the weight along the spine, in spite on the vertebral column when the person is working. Similarly, the spinal vertebral canal is made up of we go down the vertebral column because the amount of weight which a cervical spine bears is of head, which is very less amount of weight, and the amount of weight that the lumbovertebral bears is much more. This weight, as I said, is not only of the weight of the body, but because of the reactive forces generated when the person is moving, when the person is jumping, running, or lifting of the weight. So it requires a tremendous amount of structural integrity for not to collapse when it is subjected to these pressure. Now, this is oriented in a vertebral body. The line of forces along the line of weight is formed about on, or there's a compressive forces. So there are a lot of work which are able to are these transverse trabeculae. Bind the vertical trabeculae and prevent collapsing whenever there is a weighing of the vertical. Substance of the vertebral body is lost. The first thing that loses are the tension trabeculae. And once these tension trabeculae are lost, the structural integrity of the vertebral body is lost, and hence codfish spine in osteoporotic integrity and the collapse of the vertebra in the center. So this is one important aspect that you have to understand, how integrity of the bone is maintained. Then we all know that the spine moves in all the extension, lateral flexion. I have already discussed with you because of the orientation of it. It is maximum in the thoracic spine. It is lesser than thoracic spine in the cervical spine, but in lumbar spine, the rotations is absolutely minimal. The constraint to rotation is the bony structure. The rotation, which are inhibiting the abnormal rotations. Then flexion extension, as I had discussed with you, is maximum in cervical spine and much less in thoracic spine. You have to understand that atlanto-axial joint, but the rest, 40% of the rotation is in the other part of the cervical spine. When a person accesses his cervical spine, the cervical spine straightens. It never goes into a further flexion than a straight cervical spine. The lordotic curve straightens, but it does not curve forward. So that's the extent of flexion in cervical spine. There is some flexion extension in thoracic spine, and in lumbar spine, of course, there is significant amount of flexion and extension. Almost always, it is never it is taking on one side. There's a coupled movement. There's a movement of vertebra on the other axis. The rotates on the other side. So if you are flexing on the left side, the spinous process rotates on the right side. But in lumbar spine, it rotates in the same direction. This lateral flexion, again, is maximum in cervical and lumbar spine and thoracic spine because of the bony cage that is present there. Like in your elbow or in your ankle, which is a simple the center of rotation or the axis of rotation is a theoretical point where no movement takes. All you don't want, your body don't want movement to take place where the spinal so whenever the body does vertebra moves in various directions or nearer the vertebral, near the spinal cord. If it is too far away from the spinal cord, either the movement will not take place or this excessive movement can cause disruption of the whole anatomical structure of the vertebral column. However, when there is a movement take place, most of the time, this movement is not through a single axis. This movement is through an axis which goes on changing with every instant of that movement. So in cervical spine, the flexion and extension axis is somewhere here. There is almost no lateral bending because of this incinate processes here. And axial rotation is somewhere in the body of the vertebra. Okay. In thoracic spine, the flexion and extension, we have already. Lateral bending is taking place away from the side on which is. So the person is bending on the right side, the excess of rotation of bending. Lateral bending will be on the other half of the vertebra, while axial rotation is somewhere near the spinal. Then there's a term like functional spinal unit. The functional spinal unit is a term given to a segment of the spine, the smallest segment of spine between which the movement of the spine takes place. So it is a spinal spine segment that exhibits the typical mechanical characteristics of an entire spine. So when elaborated further, a functional spinal unit consists of a superior vertebra, the intervertebral disc, and an inferior vertebra. Two are bound by osteoligamentous. This is an osteoligamentous unit, so it is bound by ligaments, the disc, and the various I talked to you earlier. And what is a spinal stability? The loss of the ability of the spine under physiological load. So the loading is physiologically. Normally with physiological loading means routine functioning of a body for a person, walking, running, doing work, jumping. The loading of the spine, disruption in the basic structure, or the physiological load is within that physiological load, the relationship between the vertebra is maintained. Disruption in this relationship. But if this is lost, if the stability or the ability of the spine to work under the ability of the spine to work under to move in functional spinal unit, if that is compromised, then the degeneration starts occurring. It leads to pain. Singly or combined, everything. So I think that is what I would like to talk to you. Is there any questions, Dr. Manish? Hello. I cannot hear anyone. Dr. Kapoor, can you hear me?
I can hear you.
Yeah.
आपकी आवाज आ रही है?
Okay, now your voice is also clear to me.
Hello?
Yeah.
Hello?
Hello, Dr. Manish.
Sorry, I was in the washroom.
Yeah.
So we can go to the next lecture. Dr. Harshad, can we go to the next lecture?
I think so. This lecture is over now. It's a beautiful lecture he has given.
Yeah.
And one question I wanted to ask.
Yeah, you can go ahead, sir.
In the meantime, before you start the next one, you can ask him to get ready for the next lecture.
Dr. Sudhir, you get ready for the next lecture. Dr. Harshad will ask a question.
Yeah, this was an eye-opener to me. What are the applications for our human body with these biomechanics that you have told with respect to the examinations of postgraduates? Because generally we do not ask, except probably a disc prolapse, we tell them not to bend forward, not to lift up weight, because you already told that the weight increase is there. Can you quantify how much weight will be increased in the lumbar disc area, commonly L4, L5 and L5S1, when you lift up a mug of water or a bucket of water, when you bend forward? This is not only for the postgraduates, it's also for us to advise the patient.
Yeah, that's a... Then the lever arm longer lever arm produces a lot of stress. See, the muscles are trying to counteract the bending forces. Now, the moment of bending forces increases if the lever arm is more. If the lever arm is nearer you, then the bending force is less and the muscles are more easily able to control or balance the body. So that's how it works. And that's why it is told that whenever you want to lift up the weight, then you keep it near your body rather than away from your body.
Yeah,
Your
that's
body,
correct.
the amount of stresses is less.
That's what we want the PGs to answer.
Yes.
Yeah.
So all these operations now we are talking about regarding the stabilization of the spine, how much do we fuse, what happens if you, what happens to the next segment, all these assists in how the biomechanics of the spine works. And that's why I think a basic knowledge of biomechanics is important to our PGs.
This biomechanics with respect to gait.
Yeah. Yes. Yes, Sir Fisher.
All right, we'll talk later.
Yeah. Okay.
Dr. Sudhir, you can go ahead with your presentation. Dr. Sudhir?
He has to unmute.
Yeah, Ravi,
Ravi
please
Chauhan,
unmute him.
Chauhan can unmute him.
Yeah, he is there.
Yeah, he's there.
I'm doing, sir.
We are not hearing him.
Yeah, no.
Dr. Sudhir, we cannot hear you.
I have unmuted.
I think now, yes.
Yeah, now.
Yes, we can hear.
So this concept of stabilization of spinal column is not a new one. Even our ancestors, they knew it. And that's how you see all these photographs and practically it is being followed in villages also. And that's how this is the logo of orthopedics, which is there on the right side. And we can divide this whole implant and instrumentation in 3 different eras. The best contribution and the starting contribution by Harrington, he made in the Harrington era, where we knew much about the metallurgy. So before that, we can say this was the pre-Harrington era, where only minimal attempts were made to internally fix the spine. And if you go in the history, Hydra was the first person who used the interspinous wire in 1890. Then laminar screw was passed by King, and then Bosser, he used screw through the facet in 1959. The second generation implant came in the post-Harrington era, where there was a concept of segmental fixation, where the sublaminar wire were used with the associated component of it. The third generation implant, it gave rise to the segmental hook, cross-linked double nerve wire, and CD instrumentation system developed in this era. The last one is the most developed one, is the 4th generation, where we have a lot of modularity. And this is basically we see in the form of monoaxial and polyaxial screw. And all recent systems are included into this 4th generation. Now, if you see, this development has occurred because of the development in the metallurgy and also the understanding the biology. So we wanted to have a metal which is inert and it matches the modulus elasticity of the bone. The first generation had stainless steel material and it was basically a marine stainless steel. The second generation, people started having bioactive material and that the hydroxyapatite coated implant started coming in the market. We also had biodegradable and non-biodegradable implants. And the last one is the 3rd generation. Nowadays, even people have started trying synthetic scaffold with the help of stem cell growth factor and peptide bone cartilage. Things are being formed. Now, if we discuss about this spinal implant and instrument, you have multiple literature lying with us. But for postgraduate, it is better to know about the essential thing. So what is there which they must know? What is which is expected from them, expected to know, and what is there which they want to develop further for a good scoring is nice to know. So in orthopedic PG exam, what is the importance of this lecture? When we are talking about the implant and instrument, we have few segments where it is actually asked about these implant and instrument, and this is basically a table viva. So when you sit in front of the examiner, you start gauging all the implants kept there, and you start seeing towards the screw and these implant, and suddenly the question comes, what is implant? And you are not ready with the answer. Then on the top of it, you are again asked, can you define instrument? And you feel that you are not able to actually form a sentence to describe this. So this is important to know. Then you also have a spot where you are asked like this question, identify the person, what was his contribution in spine surgery. The second spot may be identify this implant, what is its use in spine surgery. We are not just limited to the table viva or spot. Sometimes in some of the university, you are taken to the ward, and that is known as ward round, and you have to answer this question. Now, what is this? What is the indication of this? And describe the steps of its application. So these things are important, and today we'll try to finish this, and that is the endeavor. Now, sometime in theory exam also you are asked about these implant, and you can have a short note, and sometime you can have an unexpected long question, and you'll find that no, this I am not ready, and these questions may be troubling. Just losing the. Are you able to? Hello.
You are audible, sir. Please go ahead, sir.
But am I visible?
Yeah, you are also visible, sir.
But I am not able to see. Wait. Just I am not able to see.
You are visible to everyone, sir.
Can see you, sir. Proceed, sir. We can see you.
But I am not able to see my video. Wait.
Okay.
Can someone help me?
Sir,
Yeah.
You must have done on the top of your screen. Now you must have clicked on one of the panels, like single spot, double spot.
No, actually, no one phone call came.
No, sir, just click on the Zoom icon on the lower panel. Just click on the Zoom icon.
Is it okay now?
Yeah, sir, it's okay,
Yeah.
sir. Please
Yeah.
go ahead.
Yeah. So in theory exam, you can have questions related to short note, and sometimes long question can also be asked, and we should be ready with that. Now, if you see the spine implant, which is very widely used, but if someone asks you what is that, then you are not able to answer it, and you should try to answer that question very nicely. So you say that it is a device which is used for internal fixation during spinal surgery. And what is the purpose? For the purpose of stabilization, alignment, reconstruction, and facilitation of fusion. So if you see that that implant is solving the purpose or not. My slide is not progressing. So this implant has been put. So on left side, that figure is of the heart seal, and where it has been stabilized with the sublaminar wire. So this purpose has been solved by using this implant. What is a spinal instrument? It is a tool or device which is used for performing a particular piece of work during spinal surgery. So that should be the definition of a spinal instrument. Now, you can have a specific implant like a Harrington rod, or sometimes you have different component of a system like a Harrington system. So what is Harrington system? It has a ratchet rod, and there are two hooks, that is proximal and distal hook. There had been modifications in this system, and Mohs was the person who, to provide rotational stability, made the lower hook a rectangular hole shape, so that there was a rotational stability also. There may be combination of component of different system. Like there is one system I'm just going to tell about, that initially the Harrington rod was developed, then the Luque rod came in between, and there was a Drummond wire. So a person, he combined all these things, and what it became a Wisconsin system. So what is there in Wisconsin system? There is a Harrington rod, and this Luque rod was also curved on upper side also, so make it like a C. And then this Drummond wire was actually tied to the base of the spinous process on the system. So there may be a system where there is a combination of component of different system. Now, what is hybrid system? When you combine components of two different generation of implant, then you say this is the hybrid system. I will just give you a practical example. Now, this boy is 4 years old and he has come with dense deficit, and you wonder which implant I'm going to use in such a young child. And there you have idea about these hybrid components, and then you can treat this. So this is the simple titanium rod, which was curved in the form of U. Lower down, the fixation of the pedicles were done and the pedicular screw were used. Proximally, the sublaminar wires was used. So that's how it could be done. So there is importance of hybrid system. So if you try to devise this spinal implant, you have first generation implant where practically it was the Harrington rod in books. The second generation implant, the concept of segmental fixation developed and people started using sublaminar wire. Third generation implant, CD system, where segmental hooks were used, null yard were used, and there at that moment the sacral screws were also used. In fourth generation implant, there was a well-developed spinal implant system, and basically the modularity developed. Now, if you see spinal column, the posterior surface is the tensile surface and anterior surface is the compression surface. So we should try to put the implant on the tensile surface, as we also study in the biomechanics of the appendicular skeleton. So you can have a posterior based implant or anterior based implant. So in anterior based implant, you can have a vertebral body, screw, anterior plate, stable cable and rod, and cage also. Posterior based implant, there are many systems. You can have a Harrington system, sublaminar wire, Luque and hard seal CD system, translaminar screw, and facet screw. But development of pedicular screw gave the idea of 3 column fixation. So pedicle is the force nucleus of the vertebra. But you must remember, we just should not talk about the implant. It is the bone which holds the implant. If there is a poor bone quality, the implant will back out. It will be like a nail in the loose plaster of a wall. So we must adhere to the principle of biology and biomechanics to have a long-lasting result. So we can study this spinal implant in a different way. There were implants which were put in such a way that the part of it was lying anterior, and that is known as the fixator externi. Even the Eligaro has been used in spinal column. And commonly used one is inside the body. We can use wire, screw, rod, and plate. So this was the external fixator. And later on, if the things is sorted out, it used to be changed into definitive fixation. And this was the example of this Eligaro fixation. Dubuisset had done few cases, and for this he made some changes. He made custom-made bed for the patient, and the close observation was important. Now, about the inside, where you are going to put these implant inside, you should know what are the commonly which is being used, implant as well instrument, and there may be a specific system, and you try to know that also. So commonly we use wire, rod, screw, and there are specific common implant instrument, cow elevator, Penfield, all these things we should know. In a specific implant, it will be system-wide. And if you see in the midline, we can fix the spinal column from occiput to sacrum, and you can have sometime lateral extension. We can have a rib-based implant, and we can even go to the iliac bone. Common spinal implant, we must know what is its specification, what is the use, what are the indication, and more important, what is the contraindication. So wire may be stainless steel wire, titanium wire, or it may be a braided cable. So here you can see this is the steel wire. It comes in the spool and you can cut according to the need. The diameter might vary from 0.5 mm to 1 mm, and sometimes it is also labeled in the form of the gauge. So it may be 18 to 22. So increase in the gauge size, the thinner is the wire. It can be used as an interspinous wire, interlaminar wire, sublaminar wire, or there may be supplementation to other systems. Now, when you are using this wire as a sublaminar wire, you must take care that you should not keep the wire loose inside the canal because it can lead to neurological deficit. And if you see the reported literature, it is 0.6 to 70%. So one has to be extra careful about that. Now, this wire is the Drummond wire. So there is a button where there are 4 holes. And Dennis Drummond was the person who actually invented this wire. We can also have use of Marcelline tape, and mainly it is used in pediatric age group or even in the osteoporotic spine. The hooks were then developed. Specifically, it is an implant which hooks or grips over a component of vertebra. And there may be different types of hook according to the site of the purchase. It may be a pedicular hook, laminar hook, which may be either superior or inferior, or it may be a transverse process hook. So you can see this is the pedicular hook. So it is actually inserted between the superior and inferior articular process, and this has been done in the thoracic vertebra. And that's how you should make the opening here. You make a cut like this and try to insert the pedicular hook in this direction. So you can see this is the way one should insert the pedicular hook here. Then there may be laminar hook, and there are different sizes for that, and one can use according to the need. So with the periosteum or a starter, you make an opening here inside, and then it is from the superior aspect. So this is the superior laminar hook. There may be inferior laminar hook also. So according to the placement, the name has been given. And specific hooks have been made for pediatric age group also. And these are the transverse process hook. Now transverse process, this is the transverse process and this is the rib. So here in this joint, the hook is passed. And remember this assembly is very strong. And sometime at the end of your proximal fixation, you add this and this try to hold the implant very well. Then there may be offset hook. Sometimes when you do the fixation, you find that your rod is going quite away from the line. So in that case, one can use the offset screw to facilitate that. Then there are screws. What is a screw? A screw is a mechanical device that is used to convert rotatory load, that is torque, into compression between a plate and a bone. So here you can see we have put the plate anterior cervical plate. So it is compressing towards that, or between 2 fragments. So example has been given. So there is a fracture of the dents, and with this screw you are compress these, or use as a purchase on bone as a base for additional component of loading system. And while discussing all these things, we must know about the details of the screw. And there may be question about the pitch, crest, root, what is the pitch diameter, what is the root diameter, and what is the major diameter. And these things are important to know. It is actually a basic orthopedics, and one should know about this. Now, these particular screw may be of different varieties. It may be a polyaxial, where it can rotate in multiple axes. It may be monoaxial, it may be uniaxial, it may be reduction screw. You can see this head is, or tulip is quite long. So when you try to tighten it, it pulls the thing upward. And there may be fenestrated screw, which can be used for putting the cement in osteoporotic spine. Diameter varies. It may be from 3.5 millimeter to even 7.5 millimeter. The polyaxial screw, actually, it gives liberty you to adjust with the rod, and this liberty may be in the range of almost 40 to 60 degree. Then one can have expandable screw, where when you tighten the distal part of the screw, it expands. So it has a better hold in osteoporotic spine. And this one is the partially threaded screw. and usually used in the lateral mass because there we want to avoid the irritation of C2 nerve root. Now, regarding the fixation points, so these are the two different methods which has been described here. This is the Roy-Camel method and Weinstein method. Why this one is better? Because it has more obliquity. So it's purchase and the pull-out thing is very strong as compared to other. Now, the first metal screw in the spine was actually a translaminar screw, and this was developed by King in 1944. And what he did from the base of this part, inferior lamina, he passed the screw across the facet joint. The second one was Boucher, and here he was the person who could utilize, who could know, sorry. Wait. Sorry for this trouble. Oh. Previous, I will go. Yeah, we'll leave this screw part. I'm having some unstable situation here. Yeah, now I know. Just bear with me. Yeah. So Boucher, the person, actually he tried to pass the screw through the facet and he went into pedicle, and he recognized that pedicle, it gives improved fixation. This one is a new invention where the plate was used on the spinal column. So here the screw were passed through these plate holes, and Roy Camel was the person who tried this. Now only restrictions were there. So suppose you want to put a plate there and then you are not having the hole there. So then there is a difficulty. So actually Mr. Arthur Steffi, he also solved this problem. So here he first put the screw, and on the top this plate was actually put. It has a lot of obliquity, so you can adjust the screw. So this you can see there is a hole there, and it can be moved up or down anywhere. The Wilsey, he actually invented the saddle clamp. So it increased the adaptability of fixation. Then this is the last generation, and which is the modular system, Moss-Miami system, where we have all sort of modularity. We have a polyaxial screw, uniaxial screw, there may be reduction screw, there may be use of hooks. Now the claw. Now, why you put claw? Claw resists the pull-out. So you can have a hook-to-hook claw, or you can have a hook-to-screw claw. So that's how it has been shown here. So lower one is the hook and upper one is the pedicular screw. So it provides more stability, and one can resist the pull-out thing. Then there are transverse connector. So what are these transverse connectors? These are a device which joins two rod and screw vertical construct to provide increased stability, which may be of a various variety according to the different system. So you can see there is a variation. And this is actually attached to the two parallel rods. Now, what is domino? Domino is a device which allows the extension of a construct to higher or lower vertebral level from pre-existing fusion rods. So you can see here, this may be of end-to-end variety, or it may be from side-to-side variety. So both has been seen. Now in this example, if you see, there is transverse connector also, and there is a domino also which has been used. Rod, there are different types. Metal is different. It may be made up of stainless steel or cobalt chrome titanium, or it may be titanium, and there are different diameters. Usually the thinner rod is used in the cervical or upper dorsal spine. As you go down, descend towards the lumbar and sacral area, the diameter of the rod increases. and it may be of different type. It may be a smooth rod, it may be a tapered rod. So suppose in dorsal spine you are fixing this, so it can be extended to the cervical spine where the diameter required is less. And then there was a development of knurled rod, and actually it was devised by Cottrell and Dubisset, the originator of CD system. Harrington rod, the end is different. The upper end is ratcheted and the lower end is the smooth end. And Paul Harrington, he devised the thing. Then there was a development of leuco rod, also known as L rod, and this was actually used in pair. So on one side, the L angle was lower down, and another side was higher. Then John Doe, there is disturbance. So John Dove, he joined these two L, and the heart-shell rectangle was formed and was fixed with a subliminal wire. Then what about this Galveston technique? Here, this rod was pushed into the ileum. So this is known as Galveston technique. Later on, it was actually modified by Galveston. And here the other things is also subliminal wire and with the screws also. Now, since there was separate plate and rod, there was a system where the proximal part was a plate and the lower part was the rod. And this is quite commonly seen in the occipito-cervical area. So this plate, it sits in the occipital area, and the rod, it goes down in the subaxial spine. And in cervical spine, you use lateral mass screw or pedicular screw. And that's how it is fixed there. So this plate is lying in the occiput, and this lateral mass or pedicular screw in the cervical area. We must know about this purchase point in this area, because this area is a little precarious, where there is a vertebral artery and medially there is a cervical spinal cord. So we should be aware about this. In C1, we can have a lateral mass fixation, and we can have actually the laminar posterior arch fixation also. In C2, we can have the pedicular screw fixation, laminar screw fixation, or we can use wire also. And anteriorly, the dense screw can be passed, okay? And it is important to know the point of entry. So this is the point of entry for the transarticular screw. So you be 3 millimeter lateral and 3 millimeter proximal to the inferior edge of the articular process. The pedicular screw is this is the site for the pedicular screw insertion, and you converge it like this. And this is for the C1 lateral mass screw. So these are the entry point. Now, for doing cervical spine surgery, we usually apply the cervical tongue, and this is for the skeletal traction. So these two are very commonly used, that is Gardner-Weill tongue and the Crutchfield tongue. In Crutchfield tongue, initially you have to drill a hole, and in that you sit the teeth of these, and then you tighten it. While in Gardner-Weill tongue, you make it just a small step and you just tighten it because this is quite pointed. And you should see that it enters into the outer wall of the diploic bone of the skull. Now, there is another tongue clamp which can be used is the Meffel clamp, and intraoperatively usually we use this Meffel clamp. And there are the different example. You should know what are the different fixation. There is the transarticular screw, and which has been supplemented with the posterior galleys fixation. When you are not able to achieve the reduction, then C1, C2 screw can be fixed separately, and one can fuse this area posteriorly. So for wiring in atlantoaxial region, one can have a galleys fixation where the sublaminar wire is only in the C1, while in Brooks fixation, the sublaminar wire is in the C1 and C2 both. This is Halifax clamp, where it is actually clamping between the C1 posterior arch and C2 arch. So you can have compressed this area nicely. Then the plating came in the cervical area, and Casper was the person who first devised this Casper plate. He also devised this Casper cervical distraction, where it is easier to distract that area and put bone graft or do your surgical work there. Now, there are different types of plate. In cervical plate, this is important that your hole should be such that you are able to converge the screw. And the common size screw which is used is 16 millimeters. Sometime in a small texture of the patient, there may be 14, and in larger patient, there may be use of 18 millimeter screw. Now, the concept of the case, it came to Professor Ham, and he devised first the mesh cage, which is quite routinely used nowadays. Later on, there were further development into the system, and people started using expandable case. There were a pliff case, T-leaf case, zero profile cervical case, and because of its shape in the lateral part of where it is inserted, the banana case was being used. And we can also have peak case, that is polyether ketone cage. Also, in dorsal and lumbar area, the anterior system came into picture, and quite in past very significantly used. And Dower was the person who started using staple and cable on the convex side after doing the discectomy, and he used to compress that, and it used to correct the deformity. The Gilkey started using threaded rod instead of cable, and he had the same thing. Now, the newer thing, even the disc replacement has been done in the spinal area, both in the lumbar spine and the cervical spine. Only the long-term result is not that good for the lumbar spine. So usually we find that the mobility decreases gradually. What are the common instruments used in spine surgery? We should know according to the step of the surgery. You should know about this is Gilkey detector. So it is a self-retaining detector. You can have McLaughlin detector where it is used in microdiscectomy, and in transthoracic surgery, you can use the chest spreader. There may be self-retaining detector where, and if it is double action, then you can angulate and use it nicely. There is a curve elevator, which is actually used to elevate the paraspinal muscle from the spinous process and the lamina. This is periosteal elevator, which is also used for dissection for the finer area, for the facet area and all. They are the double action nibbler. Now this angle is important because if you have a straight one, sometimes it comes in the way of your view. So this gives that facility. This is the spinous process cutter, and there are pen-filled dissectors. We commonly say it is dura, different sizes, different shape, and this is a very extremely important instrument which we must have during our surgery. We have ball tip probe for palpating the area. Even this straight one used as a feeler, so you can feel while making this particular hole for passing the screw. And the other Carrison Ronger, it may be of different type. It may be a forward cutting, 45 degree to 90 degree like this. This may be backward cutting, and there may be beveled one. Again, this beveled one helps you to clear the space there for the vision, mainly used when you do the microscopic surgery. Then there are disc forceps, which also may be of different variety and different sizes. It may be a forward angle disc, it may be a backward angle disc forceps, or it may be a straight disc forceps. Sometimes the bite and the tip sizes are different, their shapes are different, like this is a cup-shaped bite. Then these are extremely important instruments when you are planning to implant. There are some screws. So this is important. So a starting hole is made with the pedicle starter awl. And then you have a pedicle gear shift. So this is curve. So initially you face towards lateral, and then when you just cross the pedicle, you turn it and go towards medial side. Then you should have a pedicle sound. So always you palpate that you are within the bone. So you should be able to feel all 5 cortices, 4 the sides and 1 is the front. And this is the dura dissector. Then you have a different screwdriver for using in different types of screw, for the monoaxial screw, for the polyaxial screw, and for the reduction screw also. And the other different tab. So we must follow the steps which we know about fixation in the bone, and we should do that. Then only we'll have a good anchor inside the bone. Then we have bone gauge, and then we have osteotome, because when we want to harvest the bone graft, or when you want to roughen the surfaces in long cases of scoliosis, the fusion is ultimate and most important thing. So you try to raw the bone nicely, and these instruments are extremely important. Again, the suction tip may be straight or angle. Again, it gives you more freedom so that it doesn't come in the way of vision. We have different types of curette, different shapes and different sizes. They are the straight one. You can have angled one also, and these may come in the different varieties also. The devious retractor is usually used when you do the transthoracic surgery or when you do the retroperitoneal approach to the lumbar spine. They are the bone punches when you want to impact the graft, and these are quite handy and usually quite frequently used in the spine surgery. The vice grip is a very, very important instrument when you do the scoliosis surgery. So here, the holding on the rod is extremely important when you want to rotate the rod. This vice grip is extremely important. One should try to keep 2 of these on each cage. This is important. These are the in situ bender, and this is the rod. Now here, when you have already fixed the rod over the screw, you don't want to take out and again rebend it. So inside then only you can bend it, and that's why it is known as in situ rod bender. And sometimes you require locally distract or contract. So this is distractor and this one is compressor. So between 2 screws you can distract or compress. This is the H rod cutter. This is Harrington out trigger. So there, when you want to distract it, you put it here and distract it, and then you put the rod there. Now, a word about minimal invasive surgery. You have nowadays, it's a lot of minimal invasive surgery is being done. Its instrument set is different because it has to pass through a very narrow channel, and they are the special instrument. Then a word about navigation. Nowadays, this is being used for perfection. In cervical spine, in anomalies, this is being used because this is done almost like an vision to the 3D reconstruct. Word about vertebral plasty. It is done for the osteoporotic collapse. So here you put the bone cement, and this is kyphoplasty. What is the difference? In kyphoplasty, you actually correct the deformity. You open it and then you put the bone cement here. So this is the difference between vertebral plasty and kyphoplasty. And nowadays robotic surgery. So more area you can venture into with the help of this robot. Now, after doing all these things, you must understand that if the biology is poor, whatever reconstruction you did keeps on failing. So here, see, it was fixed here, now again extended, and then someday it might extend here because it has failed here also. So it might fail biomechanically. So beware of the disaster in spine surgery. So you must know what is the status of the bone in this lady, what is the biomechanical alignment, what type of implant is required in this case. So each thing is extremely important. So I'll conclude that it is extremely important to understand the specific design and material of an implant, the purpose of its use in a specific case, its effect on the biomechanics of the spinal column, and its limitation. That is extremely important. Remember, implant cannot make castle in the air. It is the bone which holds the pillar of axial sculpture. I thank you very much for your kind attention, and I best of luck for all exam going students. Thank you.
Thank you, Dr. Sudhir Srivastava, for such an excellent and very important topic, because this was a kind of a lacuna. Now over to Dr. Rajgopalan. Dr. Rajgopalan.
Yeah.
For your comments and discussion, yeah.
Thank you. So it's a very nice talk, as usual, excellent. You have completely told everything which the postgraduate needs to know. All the faculty, the talks are very nice. How many questions we have pending, Manish?
No, not much, sir.
Not much.
So we can have 2-3 questions from the panel.
Yeah.
You can initiate that, and we can just have a discussion within the panelists, and then because we have exceeded our time, so we have 10-15 minutes, and then we'll wrap up.
There's only one thing I just want to add, which was discussed when during Rajshekh's talk about the per-rectal examination. The only thing is what we used to tell in the DNB exam or even the FNB exam, the candidate should take the permission of the patients, particularly when it's a female, and also the examiner. You can inform the examiner, and they should do it only when they are given a green signal. Because sometimes we would already discuss with the patient and taken the consent before giving the case. So that's the only thing I wanted to add. Other things were generally speaking important in practical life, but this being a PG teaching program, it is better the student ask the exam.
Professor Lalit Mani, your comments, please.
Very, very extensive and good session it has almost covered everything what a postgraduate student requires. And I'm sure once the student absorbs all this information, by tomorrow you're going to get a lot of questions, and you might have to do a question session like the hip session.
I think so. We are heading towards that because,
Yeah.
so much of material has been given, and, probably we will see because next session is a clinical session. We
Yeah.
might,
You
take
can start with the questions in the clinical session,
Yeah.
and then maybe take it that way. Excellent session. I think the last lecture on instruments and implants was really refreshing. It took us to the history and took us back to
Actually,
RPG
this
times.
session was kept by, demand from the postgraduates. It was actually initially was not there, but the postgraduate demanded that, no, we want to know because this is a kind of lacuna. So we kept and we requested Dr. Sudhir. Dr. Naresh Babu, your comments, please.
I thoroughly enjoyed, actually learnt a lot. I've been listening to Rajshekharan sir after 10 years.
Okay.
Manish, there's one thing I want to mention. Manish, with your permission. Naresh, I liked your talk very much because that's the basics that postgraduates have to know. It was very nice. I mean, because we have to keep in mind that this is for the postgraduates, same thing about the implant and all the talks for that matter, but we all have to probably remember that this is more than for the consultant, mainly with the exam point of view for the postgraduates.
Dr. Hemant Chatterjee, are you with us? Dr. Hemant? Dr. Hemant? Dr. Prashant Dwivedi? Dr. Prashant?
Yeah, it was a very nice session, sir. Only I would like to request one thing, that if we can make a fixed time slot so that it will be more, it's not possible for everybody to be present, even for PG student, I think, for such a long duration.
No, I
we
totally
can fix the time slot.
No, actually time slot was fixed. But what happens that when a lecture is going on, because it is onus is on the speakers to limit their lecture according to the time. But what happens that, on the WhatsApp chat, what I get audience says that please do not cut short. We might miss anything. Exams are coming. So if you will shorten this lecture, then we will miss something. So these issues are starting. I have around 15 this thing that you will not shorten. And actually, it is the onus is on the speakers to limit because we are given the time limit.
So if no, I agree. If PG students are willing, then there is no problem. Then it can be carried out.
Doctor,
can I make
otherwise
a
it was very good.
Yes, sir. Yes, sir.
Can I make a suggestion?
Yes, sir. Dr.
Now,
Sudhir,
if you see the program declared program is 6 to 8, and the time which was given to all faculty, if you add it, it is 2 hours 45 minutes.
Yeah.
So to start with, we did not expect that this will finish at 8 o'clock in any way.
Okay.
And moreover, there was disturbances. Like you see my slide also now, I don't know what happened to computer. It started running without any control. So sometimes it happens, you have. But what I feel, you keep 2-3 lecture, but try to cover it full, so that we are also not in hurry to, there are many questions which I could not actually ask during my talk only. See, these are the questions which I try to make it like exam oriented, so that if they get in either spotting or their table viva, so they should be able to answer it. But if from the beginning, if we have 5 lecture, you don't expect to finish in that much duration. It is a poor expectation.
Agreed, sir. Because clinical also we have 5 long cases. So, but we have to finish the course. We can take one more spine session. Maybe probably it will be required the third one. Dr. Prashant has come. Dr. Prashant, your comments, please.
Yeah. No other issue from my side. That was my only suggestion, that if we can stick to some extent to time, at least we can give 5-10 minutes liberty, but in spite of 2 hours, if we go to 4 hours, then gradually maybe people will lose interest. That was my only concern.
Dr. Ashok?
Otherwise, it was very well organized, sir.
Okay. Thank you, sir.
Thanks to all of you, and I congratulate to whole your team. It was very nicely organized program. Thank you for giving us opportunity.
Welcome, sir. Dr. Ashok Burnwal. Dr. Ashok. Dr. Govind, are you there? Dr. Govind Gupta. Dr. Hemant.
Yes.
Any comments?
Yes, I am back. I went for a small emergency in between, but I have thoroughly enjoyed the things. The material was fantastic. And it was very nice hearing our old teachers, Dr. Samir Gupta, Dr. Rajshekharan. It was a fantastic academic feast. But only thing is that the time limit was absolutely exceeding. So we lost many of the viewers in between. No issue. We have to keep on trying this, and covering the good topics together is a very nice thing which we have done. Congratulations, Dr. Manish Dhawan, Dr. Chauhan, and entire team of IOA from our behalf, from CG State. Thank you so much for joining us and being a part of this group. We are really proud to be. Thank you so much.
Thank you, sir. Dr. Govind.
Thanks, sir.
Dr. Govind.
Thank you very much, sir, for giving this opportunity. And it is very useful topic, and it is useful presentation by all of us. And it is great benefit for the students of our orthopedics department. And thank you very much, sir. Thank you very much.
Welcome, sir. Dr. Harshad.
Yeah, superlative as usual, Manish. Wonderful. You, all of you have done really very well.
We have problem with the time limit.
All the speakers have also done well, but I still think that you have to limit the time for all the lectures. That is one thing. Whatever amount they have to say, half an hour should be enough, whatever topic is given.
Yeah.
Second thing, I think when you start the clinical examination course for the next time, you should have a small pro forma made by somebody who can tell that when you write in the examination, the full case sheet, you write it under these headings so that you don't miss the major parts of it.
Yes, very good.
That's what was missing today. And I think that lecture you can start with that lecture. I think Rajgopal and I can do that. He can start one lecture as chairman of PG training course, how to examine a spine and what to do, under what headlines you do. Detailed examination of everything is different. Just the headlines. Like
I agree with you, Harshad, but like Manish said, if you talk to the postgraduates, all of them, they really want it to go completely rather than we had kept a time 8, but we knew.
There is no time for completion at all. In 2-3 hours, you cannot do justice for such large topics where specialities and super specialities are there, even under spine. For trauma, there is different now. For scoliosis, there is different because there are too many things in that. At the postgraduate level, what we need to know, how we examine a spine patient, the headlines, how we write. Otherwise, there's too much. They'll get confused what to know, what not to know, what not to write and what to write.
Whole spine cannot be covered. This is only some topic.
Yes,
that's how it is. I also learnt a lot today, revised a lot today. It was very good.
Definitely.
We all
fantastic.
No doubt.
Dr. Samir Gupta. Dr. Samir.
Manish, that was a very nice session. I really.
Samir sir, we can't see your face.
Yes.
So can you see?
You are there now.
Yes, sir. We can see
you
you.
now.
Yeah, sir.
Yeah. See, I enjoyed the session. It was very good. I have been involved, Hemant.
Yes, sir. Good evening, sir.
Teaching. Good evening.
Very nice to see you, sir.
Teaching since a very, very long time, and that's a usual thing that my students, they want to continue for us together. They are ready to wait.
Yes, sir.
We had been conducting sessions from 8 a.m. to 10:30 in the night, and still they are ready to go on. There's a zeal.
So I think thanks to Corona that we had this opportunity for the virtual meeting, and almost today I will tell you the count because it's a very high count. How many people had viewed us? That I will put it in the group once we do the full counting.
Okay, sir.
And all the videos, all the lectures will be recorded and they will be available on the YouTube, so anybody can go and go to them if they want. They can listen to those lectures in the YouTube. So,
Very
Dr.
nice, sir.
Rajgopalan, final your comments and then we end the meeting.
First of all, I thank
And
all
Dr.
the faculty.
Dr. Sandeep also.
Sandeep is there. They're part of the team. I thank all the faculty who have come and taken their time and explained nicely. Also, all the invitees and the panelists. And I think Ravi, Sandeep, Maini, they're all part of the team. So Shah. So I thank all of you. And Manish, no thanks, because he is the person doing everything.
Yes, sir.
Okay, I think hopefully our team will be back on next 2 weeks later.
No. Next week is the clinical long cases of spine.
Next week or 2 weeks later?
Next week.
Next week. Okay. Then we meet the next week.
Dr. Sandeep, last comment.
Yeah. It was a wonderful good evening to all. And I think the best lectures were usually what happens, the biomechanics part is left behind. And also the implants, the generations which have been told today, even I myself were a few of the things were very new to me also. So I think that part was very good. And the idea of proforma is always there. The proforma has to be there for everything, just for the sake that one should not miss the basics. Because in PG exam, we want the basics. We don't want any hi-fi. We don't want any hi-fi surgery from the PG student. It's if they stick to their basic principles and they pass. So that should be the dictum. And we should try to tell them that don't make mistakes in your basics. That's it. We don't want anything hi-fi from it. And I think I congratulate everyone. All the speakers did wonderful job. And thank you very much to all of you.
So thank you all. And please, we meet next week.
Good night.
Sir, pranam karta hu.
Yeah.
Hi, Sudhir.
Dr. Ashok Sham, we
Good
can
night.
close
Savi
the
sir ko
meeting.
pranam.
Good night, Hemant.
Good night, everybody.
Sudhir sir, good night.
Dr. Ashok. Dr. Ashok
Shah,
Sham.
good night. Maini, good night. Ravi, good night.
Bye. Good night to all.
Govind, good
Good
night.
night, sir.
Good night, all of you.
Ravi, you can end the meeting. Dr. Ashok
मैं
Sham.
just कर रहा हूँ. नहीं, मैं डॉक्टर श्याम को फोन कर रहा हूँ एक्चुअली.
आप मीटिंग लाइव रिकॉर्डिंग बंद कर दो.
हाँ, मैं कर रहा हूँ.
Actually, you know what happened? You have stopped the recording?
नहीं, not yet.
Not yet.
Stop, then I will tell you something.
Off the record.
Regarding the proformas which you are asking, I think we have a fixed proforma at Ganga. All FNB students will have for disc one proforma and for TV spine one proforma.
I think, sir, if you can provide us, we can
try to collect them. And
even Dr. Harshad has promised her, in Ramaiya they have a specific proforma for the exam.
2 minutes.
No. I have told general examination of orthopedics. From that point of view, if you want, I can help you out. That
Yes,
Naresh
sir.
gave that lecture, no? It's almost the similar thing.
And you will be surprised that, there was a PG exam in SMS Jaipur. And one student was given hip case and he quoted Dr. Naresh's video and his technique.
Yeah, good. That's nice. No, my idea is not how to pass, how not to fail.
Yeah.
You understand? So you don't make major mistakes. So major mistakes are when they examine a patient, they don't do systemic examination at all. When they come to systemic examination, we may tell them, all right, don't worry about that, go to the next general physical. But then that's what happens. They totally miss systemic examination, then they don't have a right to pass. It becomes difficult.
Dr. Ravi, you have stopped the recording?
नहीं, not yet. कर रहे हैं सर, अभी ये कर रहे हैं 1 मिनट.
Oh my goodness.
As a dictum, I think we should have proforma for all the long cases.
Actually, Professor Lalit Maini is making that OSCE DNB program. Because he has selected a group of teachers who are involved in that OSCE. So he will do it in 2 programs, 2 weeks, probably end of July and first week of August.
Okay. Last week of July and first week of August.
Last week is it?
Yeah.
So he will tell us the virtual, because this is the first time from 18th August, the DNB exam is there. So before that, we will have it. So Dr. Professor Maini has taken the charge of that.
Very good.
Okay, sir. Okay. So we end the meeting and see you next week.
Bye, sir.
Okay. Good night, everybody.
Okay. Good night, all.
Good night to all.
Good night.